Today we have another session of RISA DNB online academic activities. Today we have with us a case scenario of a road traffic accident and followed by theory question answer presentation by our Perambur students. Over to professor and students with the case scenario first.
Right.
Dr. Venkat from RS Perambur and Dr. Sanjeev Raju from Western Railway and Dr. Pankaj from Northern Railway and Dr. Abby from Eastern Railway. They are all ready with the case presentation, sir. Dr.
Right.
Venkat to start the case presentation. Thank you.
Okay. Right. So you all know the case scenario, what is being given, isn't it? So Dr. Venkateswar Rao or Venkat, who is going to present? There are two people.
Venkateswar Rao, sir. Good evening, sir.
Good evening.
Venkateswar Rao.
Okay, Venkateswar Rao. You can start the presentation.
Sir, sir, here is a case scenario. 24-year-old motorcyclist brought to ER emergency department with profuse bleeding from nose, ears after a road traffic accident. His breathing is noisy. He opens his eyes to painful stimulus, moves and flexes his arms to painful stimulus. Then how will you proceed and manage the patient?
Okay.
That is the case scenario, sir.
Very good.
Sir, this is the case of RTA with GCS around 7/15 as given in the scenario with possibility of upper airway obstruction due to profuse bleeding from nose. So my primary aim is to protect the airway starting with trauma evaluation, sir, which includes primary, secondary and tertiary survey. Coming to the primary survey, that is adult trauma life support. It should be performed rapidly but completely in order. Systematic consistency is paramount to avoid missing injuries. First is airway. The aim is to protect the upper airway with taking care of cervical spine injury. Start with a quick history and brief examination and insert a wide 2 wide 4 IV cannula and connect all the monitors which include SpO2, ECG and NIBP. If you are anticipating any delay in intubation regarding arrangement, insert a appropriate size nasal airway with oxygen supplementation. Take a informed consent for endotracheal intubation. Next, make sure properly functioning suction apparatus, difficulty airway cart with availability of different sizes endotracheal tubes are available. Properly working appropriate size laryngoscope blades and bougie, all gadgets essential to tackle difficult airway is available. Inform the ENT surgeon for any backup for surgical airway and also for nasal packing and ear pack to arrest bleeding. So my plan is rapid sequence induction with manual inline stabilization of cervical spine, avoiding neck extension.
Very good.
So starting with the rapid sequence induction, unless proven otherwise, it should be taken as a full stomach. So use a available appropriate size transparent face mask. Pre-oxygenate the patient at least for 3 to 5 minutes. Pre-medicate with anti-silogogue, mild sedative, small dose of fentanyl, and RSI rapid sequence induction can be done with Selix maneuver by applying a cricoid cartilage anterior and posterior. Once the patient is induced, and the pressure should be backward, upward. So the induction can be based on the hemodynamic parameters. So if the patient is hemodynamically stable, then you can go for low dose of propofol. You can go. If you are finding any hemodynamic instability, then go with etomidate. So once the patient is induced, intubate with scoline 1 mg per kg body weight. There are some controversies the use of scoline, and it may transiently increase ICP. However, anticipating difficult airway and also with rapid sequence induction, I will choose scoline. But the other alternative is rocuronium 1.2 milligram per kg body weight. But make sure that the patient is able to intubate in time. Other disadvantage with rocuronium is the immediate neurological assessment is not possible. So once the endotracheal tube is placed, check for proper placement by 5-point auscultation. And if you are heard any adventitious sounds, do a ET suction. Avoid nasogastric tube placement. If at all required, go with orogastric tubes. Before commencing positive pressure ventilation, make sure at least clinically there is no evidence of tension pneumothorax as evidenced by hypotension, engorged neck veins, absent breath sounds, and hyperresonant on percussion. If you are suspecting any pneumothorax, place a wide bore needle at second intercostal space in mid-clavicular line till definite ICD insertion is done. If endotracheal tube is obtained and placed and secured, and ventilate with bag and mask ventilation or connect with ventilator.
Yeah.
Sir, ventilation strategy, sir. Use low lung production strategy with low tidal volume around 6 to 8 ml per kg. Avoid as much as possible PEEP and maintain PaCO2 around 30 to 35. So hypercarbia and hypocarbia both are injurious and may affect the CPP, cerebral perfusion pressure. So coming to the circulation, look for any hypotension. If at all there is there, start vasopressors and fluids not liberally, so that to maintain mean arterial pressure around or more than 80 millimeters of mercury or systolic blood pressure more than 100 millimeters of mercury, so as to maintain the cerebral perfusion pressure. For full and regular pulses are positive indicators. But if you are finding any fast, thready or diminished pulsation, likely delineate poor global outflow or decreased flow to the affected extremities. If you are anticipating any irregular pulses that it may indicate blunt cardiac injury, it should be evaluated thoroughly. Coming to the any disabilities. So as already assessed, the GCS is 7/15. So follow the methods to reduce the ICP, intracranial pressures if you are suspecting any raised intracranial pressure. So pupillary size and reactivity towards light also should be assessed. And spine injury also should be assessed, any injuries. So intoxication under alcohol influence, if at all present, masking a closed head injury. Coming to the environmental control or exposure, or clothing and dressing need to be removed to inspect for injuries and examination. After assessment, patient should be covered as quick as possible and warmth maintained. So urinary catheterization should be done. Make sure there is no injury to the urethra as evidenced by the appearance of blood in the tip of the penis. Gastric aspiration to be done to assess any stomach contents for blood and evacuate the stomach to lessen the risk of aspiration. The patient may require any arterial line or CVP line if you are suspecting any instability, but this should not delay definitive care. Then in order to reduce the ICP, the following strategies can be maintained. So we can give the drugs which reduce the cerebral edema in the form of osmotic diuretics, that is mannitol 0.5 to 1 gram per kg, but make sure that urinary Foley's catheter is placed and there is no evidence of any pulmonary edema. Or you can use hypertonic saline can be used, or furosemide in the dose of 0.5 mg per kg can be used. So once the patient is stabilized and thorough evaluation is done, then the patient can be shifted to CT scan and fast can be done, and chest X-ray, AP and lateral view can be done, sir.
Okay.
Sir, thank you.
So you have completed your description. Okay.
Sir.
Right. So from the case scenario, first of all, you have just assessed the GCS. So patient is not in a position to give any clear-cut history. So you have to rely only on the standbys or people attenders who bring the patient to the ER. Okay. So with a GCS of 7, there is no eye opening. There is only a flexion of the limb for painful stimulus, and the patient is only moaning. So naturally, you cannot elicit any history. In a case, this is likely to be a case of, first of all, a case of polytrauma. You agree with that?
Yes.
Possibility, because it has been said that it is a case of motorcycle accident, high-speed motorcycle accident. So it is likely to be a case of polytrauma, predominantly with a CNS or a head injury because of the low GCS. Okay, so we have to rely only on the attenders or the bystanders history about the patient's mode of injury and how long or what is the time interval, because golden hour is a very important information that we need. So at what time exactly the accident happened and how long it has been since the patient has been brought to the hospital. What is the importance of golden hour and who described that golden hour?
No ideas.
No idea. Okay. Golden hour is described by one Dr. Richard Adams Cowley in Baltimore, USA, way back in 1952. When he found out that patients who suffer from polytrauma coming to the ER, if the active resuscitation and treatment is not started and initiated within the first hour of the injury, the mortality and morbidity is very high. So any patient, when he comes to the ER, first and foremost information we need is what is the time lapse between the time of occurrence of the injury to the starting of the treatment or evaluation of the patient. So that is a very important history that we should get. And secondly, in this case, they have said that there is bleeding from nose and ears. So nasal bleeding can be due to direct injury to the nose, or there may be a injury to the
skull base.
Cerebriform plate or ethmoid,
Base of skull.
Base of skull, you will get both nasal as well as the ear bleeding. Okay, so we have to suspect that sort of injury in that. And I think you mentioned about nasal airway. In the presence of bleeding through the nose, I don't think nasal airway should be introduced.
Nasal, oral airways.
But I heard that you mentioned about nasal airway in your description. Please check your notes and see whether you have written anything like that. So before the airway, first thing is to clear the airway by suctioning and minimal positioning. At least jaw thrust can be given even before you try to extend the neck. We have to avoid extension of the neck because all cases of head injury have to be suspected to have cervical spine injury unless otherwise proved. That is the dictum in trauma management. So we should not, without any evidence, the patient is conscious, he may be complaining of severe pain in the neck or deformity may be there. But in this patient with a GCS of 7, we cannot get all those history. So until otherwise proved with an X-ray or a CT, we have to treat all the patients with either a cervical collar or an inline stabilization. You cannot be doing manual inline stabilization for a longer hours. So as soon as the patient arrives, it is always safer to apply a cervical collar and stabilize the cervical spine. And if the breathing is noisy, so there is some either an aspiration or obstruction. So that should be the reason for the noisy breathing. So we have to simultaneously check the oxygenation of the patient and start supplying high flow oxygen before we plan for a definitive airway securing, either by endotracheal intubation or an LMA as the situation warrants. And you described all the methods how to go about to secure the airway by endotracheal intubation. But before that, you have to make a quick assessment or survey of the possibility of a difficult airway. For that, you have to do a quick examination of the mouth opening, either manually. You have to open and see whether there is any broken tooth or jawed mandible fracture. All these things have to be ruled out. And then you have to have a difficult airway cart and an assistant all the time. Of course, you are going to do a RSI, so there will be definitely an assistant to manipulate the airway. But you must also have some assistant with whom you can rely upon for inserting a bougie and then loading the endotracheal tube. For all that help, you may need a assistant in addition to the person who is giving the Selix maneuver. So all these preparations have to be done. And you must use the word A, B, C, D, E as the initial primary survey steps. So airway has to be cleared and secured. Breathing has to be assessed, whether it is tachypneic or shallow, or whether it is a flail chest or whether it is pneumothorax. All this type of pattern of the breathing should be assessed. Circulation, you have to find out what is the pulse like, whether the volume is good, whether the capillary refill time is normal, whether there is any overt or external bleeding seen in the patient, which can be the cause of any hemodynamic instability. And if there is any immediate overt bleeding seen, measures should be taken to stop that hemorrhage, like application of a bandage or a tourniquet or elevation. All those things have to be thought of to stabilize the patient. And then comes the disability. Quickly, you must find out whether the patient moves all the four limbs, whether there are any obvious fractures in the long bones, whether there is any soft tissue injury like degloving injury or blunt or penetrating injury in the chest and the abdomen. So all these things we have to yeah, power restored. Okay, so are you able to hear me?
Very clear, sir. Sir, clear, sir. Very clear.
Okay. So so A, B, C, D, E, the disability and exposure. So, but after exposure, you should not allow the patient to remain without clothes for a long time to prevent hypothermia. So all measures to maintain warmth is very, very important. And based on the GCS, we have to define the degree of head injury. So how do you classify the status of head injury based on GCS?
Mild, moderate, and severe, sir.
Mild, moderate, and severe. So what is the scoring? How do you use
13 to 15, 13 to 15, mild, 9 to 12, moderate, 3 to 8, severe.
Severe. So this belongs to which category?
Severe, sir.
Severe category. Okay, so that is a very important classification that you have to do so that we can take appropriate steps. Now, what are the two things we have to take care of if you have made a diagnosis of severe head injury based on GCS?
Protect the airway to maintain the cerebral perfusion pressure. To maintain the cerebral perfusion pressure, sir.
Two things. One is prevent hypotension at any time. So maintain at least a minimum mean arterial pressure for cerebral perfusion to happen. Second thing is prevent rise of ICP. Increased intracranial pressure should be avoided. These are the two important things once you make a diagnosis of severe traumatic brain injury. Okay. So what are the why these two things are important? What is primary traumatic brain injury and secondary brain injury?
Primary, the event, the insult, sir. Insult happened.
Yes. Primary is caused by the injury, the direct injury or stroke or whatever. What about
secondary? Due to raised ICP.
Raised ICP,
leading to decreased cerebral blood flow.
Hypoxia, hypotension,
Hypoxia.
inflammatory cytokines. Even in sepsis, you can infection. All these things can lead to secondary brain injury. So, what is the histological difference between a primary brain injury and the secondary brain injury? How is histologically the various zones of injury are described?
Infarction is a primary injury.
Central will be
Penumbra.
infarction.
Penumbra.
Surrounded
by area of edema.
Hyperemia, edema. Then there will be the last hyperemic stage. So the main idea is to prevent that penumbra to also go in for infarction. So that can be reversible. So there is a temporary ischemia to that second zone. And by aggressive correct treatment, we can reverse that damage. And what is the amount of blood supply that is normally going to the brain tissue?
50 ml per 100 grams per minute, sir.
Very good. So what will happen if it reduces to 40? What will happen if it reduces to 30? What will happen if it reduces to 20?
Cerebral ischemia and
every 10 ml decrease in 100 grams of brain tissue blood supply. What are all the changes that you expect?
ml.
When it decreases to 40, you get edema, cellular edema. Okay. When it decreases to 30, what happens? There will be electrical activity will be reduced, and the metabolism will stop. When it reduces, 20 should be the minimal. So we must try to maintain at least 20 ml of blood supply minimum, so that the damage can be minimized and there is a possibility that the brain tissue can come back to normal. Once the blood supply reduces below 20 ml per 100 grams of brain tissue, then there will be irreversible damage. So when it goes to 10 ml, there will be a total flat line in EEG. That is almost like a brain death that is happening. That is why one of the tests we do for ancillary tests we do for declaration of brain death is EEG is for electrical activity, but blood supply. We do transcranial Doppler or 4-vessel angiography. Okay, so one of the ancillary tests that have to be done to confirm brain death when there is no the regular cranial nerve examination and other things are not possible. You can go for EEG, you can go for transcranial Doppler, or you can go for 4-vessel angiography of the cerebral circulation. So all these things they get decreased in brain death. So the two important things that we have to take care of once we know that it is a case of severe traumatic brain injury is prevention of hypotension and prevention of raise of intracranial pressure. So the primary concern is to maintain circulatory stability. Okay? So for that, what is the best fluid of choice?
Normal saline.
Normal saline?
0.9%.
Or?
Ringer lactate.
Ringer lactate should not be given. Why?
Or 3% NS.
3% NS is more for anti-edema measure. It is not to be used for resuscitation purpose.
Plasmolite, sir.
Plasmolite, yes. You can use plasmolite and
0.9% NS.
Hypotonic solutions like ringer lactate and
glucose.
All these things should be avoided totally. Okay, so that is very important. They themselves will raise the ICP. And so the main important thing is to take care of that. And ventilation. Can you do hyperventilation? You said about ventilatory strategies. When will you resort to hyperventilation, and why hyperventilation, which was advocated earlier in the early periods of trauma anesthesia is now not recommended.
Cerebral hyperventilation causes cerebral vasoconstriction, sir. Decreased hypocarbia, it causes cerebral vasoconstriction. Ischemic changes may be there, sir. So it's better to advocate 30 to 35 mm of Hg. If you hypoventilate, there will be increased carbon dioxide and vasodilatation and increases the ICP, sir, and reduce the CPP. So both are not advocated. No, normocarbia is better.
Better to be normocarbia. But for a transient, if there is a what is the dire emergency during which you can temporarily hyperventilate? When there is a severe brain injury, traumatic brain injury, as elicited by the GCS score, what is the only indication for a temporary or transient hyperventilation?
Cerebral edema, sir.
Cerebral edema, the reduction only we are doing the hyperventilation. But what is the indication? Which clinical sign will tell you that you can hyperventilate to prevent a major catastrophic damage? What is Cushing's sign?
Hypertension, bradycardia, increased pressure.
Bradyapnea.
Bradypnea, bradycardia, and hypertension. These are the three things which indicate that there is a coning or the herniation of the brainstem. Okay, if that is present, you can reduce the ICP by hyperventilation to some extent for about a maximum 25 to 30 minutes, so that you can do other measures like lumbar CSF drainage or external ventricular drain. All these things can be attempted to reduce the ICP. Okay, that is the only indication for doing hyperventilation on a temporary basis. Only when you suspect a what is called the brainstem herniation or the coning, which is likely to kill the patient immediately. Okay. Now that will lead to the question: what are all the various herniations that can happen by raised ICP? Where all the brain can herniate?
Foramen magnum, sir.
Foramen magnum is ultimate.
Uncle herniation.
Tentorial. What are the names for those herniations? There are 4 sites where it can herniate through falx cerebrum. It can herniate through tentorium. It can cerebrate through the subtentorial area. It can herniate through the foramen magnum, which is called the tonsillar or the cerebellar herniation. Okay. So each one will have different clinical picture. In which one you will have pupillary signs?
Uncle herniation.
Uncal and transtentorial. Okay, that is where the third nerve compression will happen and pupillary signs will be present. Okay, so these are the observations that you have to make. So the initial resuscitation should be done maximally within the first hour of receiving the patient or within the first hour of injury, and that is called the golden hour to achieve the maximum benefit. And once you finish the primary survey and then you simultaneously resuscitate the patient, you review the results after a few hours and then go for the transfer of the patient or further advanced therapy in a tertiary care. So the ATLS protocol calls for 4 steps. One is the primary survey, second is the review, third is the secondary survey, and fourth is the tertiary care or the transfer to higher institution. So these protocols should be followed, and these are the things that you have to carry on in these patients. So I'll just try to show you the PPT on that.